Good evening, everybody. Welcome on to this surgical conversation with Alcon this evening. We have a live audience here, and also welcome to all the virtual audience who have tuned in for this meeting. So the main objective of this meeting today is to discuss about the recent advances in technologies as well as in clinical research with regarding to cataract surgery. I'm delighted to introduce my co-chair, Mr. Richard Packard, who doesn't need any introduction. We have got 4 experienced clinicians and speakers who will be sharing their experience with various technologies today. James Ball from Leeds will be talking about advances in intraocular lenses. Particularly, he's going to share his experience with his Vivity and his own personal results. Arthur Cummings from Dublin, Wellington Eye Clinic, will be talking about the newest advances in IOL biometry, about the Argos, and Sanjay Mantry will be from Glasgow will be talking about his experience with Argos and also the associated image guidance system. And finally, the last talk would be from Guy Smith from Swindon. Will be talking about the importance of ocular surface disease and dry eye with regards to refractive cataract surgery. So without any further ado, I'll hand over the reins to James Ball to talk about his experience. James.
Thank you very much, Sathish. So being given the brief from Alcon to talk about the ability of lens technology to enhance the quality of life for our patients. These are my financial disclosures. So at the start of cataract surgery, we didn't need randomized controlled trials to tell us that removing a dense cataract improves the quality of a patient's life by treating blindness. And similarly, once intraocular lens technology got going, it was clearly far superior to having to wear aphakic spectacles with their cumbersome nature, cosmetic appearance, jack-in-a-box effect that patients had to put up with. And then we've seen rapid progress with improvements in our ability to measure eyes with more accurate biometry, deliver lens technology through tiny incisions, and a really wide range of powers of lens are open to us, such that we can really accurately address refractive error and achieve good correction of spherical error for our patients with these wide diopter ranges. And with these improvements in measurement and reduction in size of incision for surgery, we were then able to move on and really accurately and extremely well correct astigmatism for our patients. There are imaging guidance systems available now. There's a really nice editorial from David Spalton in this month's JCRS where he acknowledges that actually the guidance systems aren't providing that much in terms of clinical benefit. It's mainly improving throughput. And it turns out that there's this interesting tolerance with toric lenses that as long as you're within a few degrees of your target axis, you're going to achieve really good refractive outcomes for our patients, which is something that was elucidated in a nice letter a couple of years ago in JCRS. We'd been laboring under a misapprehension of being too fearful of how many degrees we could get away with lost effect. And it turns out that, as you'd expect, it's only when it gets to 45 degrees away from your desired axis that you lose all the effect of your toric lens. And in fact, it's a non-linear effect. So the first few degrees of misalignment, you're still getting really good correction for your patients. So I still use a pen and a Mendes marker, and it's over 300 eyes since I've last had to rotate a lens. We do have data to support the effectiveness of intraocular lenses, toric intraocular lenses, to correct astigmatism. And in fact, there is one study showing an improvement in quality of life. They used the National Eye Institute Refractive Error Quality of Life Instrument 42 questionnaire, and a beautifully controlled study. So patients with greater than 1.5 diopters of corneal astigmatism, 40 of them, control eyes with no astigmatism, and then 40 eyes with greater than 1.5 who had toric lenses. And in the toric lens corrected group, there were superior outcomes in terms of clarity of vision, clarity of distance vision, reduction in glare, and patient satisfaction with correction. As we move into the noughties, we've got a story around using lens technology to correct spherical aberration. And it was AMO, then became Abbott, then became Johnson & Johnson, who first gave us the Technis lens. And this had negative spherical aberration built onto the optic to neutralize the average positive spherical aberration of the corneas in our patients. And the first study suggested that this could lead to improved contrast sensitivity for our patients, potentially improving their safety when night driving, when wearing their spectacle correction. The issue, of course, is that this was an average. Also, it didn't appear to be that clinically relevant. And also, it resulted in a reduction in depth of focus. So if the stars aligned and you had a patient where you neutralized the corneal spherical aberration, you had no astigmatism, no spherical error, they could see perfectly a mile away. Anything that came closer was gradually going out of focus. And this has led to a change of direction such that we're now trying to optimize spherical aberration in our patients. And most recently, this has led to my boss, Graham Barrett, developing his EMV lens, which actually induces positive spherical aberration in the eye in order to increase depth of focus and provide increased spectacle independence, and allowing these lenses to be used in a blended vision type approach. We don't have anything, any data on how this impacts on quality of life for our patients. Multifocality is how lens technology has helped us help our patients with the issue of presbyopia. And the most successful lenses in this domain have been the trifocal lenses, three main platforms that we're used to as clinicians: the fine vision, the Zeiss trifocal, and the Panoptics. These things work. This is a beautiful big study from Spain, over 10,000 eyes. It was the fine vision and the Zeiss, over 90% of patients achieving complete spectacle independence, but this issue becoming evident. And bear in mind that this is Spain, this isn't North Yorkshire. So this isn't the same impact on quality of life when we're talking about night driving. But fully 2% of their patients had stopped driving because they didn't feel safe because of a halo effect. And almost 9% felt their night driving was significantly impaired. Now, this was a non-validated questionnaire. This was developed by the study group, and this is something that we see a lot in these various different studies. There is an evaluation of quality of life in a series of patients who've received Panoptics, but the VF14 is 18 questions relating to 14 aspects of visual function, and it's actually designed to assess impairment from cataract. So it isn't really designed to assess quality of life improvement as a result of increased spectacle independence from utilizing a trifocal lens implant. But because of the limitations we're aware of with the impact of trifocality on impaired quality of vision when driving at night, there's been a drive for quite some time to extended depth of focus lenses. Various different manufacturers have had different optical approaches, as we see outlined here. And the space was first defined by the Symphony lens from AMO, Abbott, Johnson & Johnson. And it was put forward as a lens that had a new technology to provide us with increased range of focus without the downsides of multifocality. So they designed an optic that helped reduce chromatic aberration, and that bought them some optical space to increase the range of focus, was the story around the lens. And what we were told is that we could have the side effect profile of a monofocal lens, but with increased spectacle independence. This range of focus, good night vision. If you put it on an optical bench, you find it's a diffractive grating, and there are 2 points of focus. And that actually, yes, some patients had great range of vision with great visual quality, but some patients had the downsides without the upside, so terrible night vision and poor range of focus. And this is a patient of mine in whom I had to change a lens last month, and this was 3 years after I implanted her with bilateral Symphonies. And the conversation went, James, I need reading glasses and I can't drive at night. You can see there this identical capsular bag. I've literally just swapped a Symphony for a PCBoo. And yeah, sure, she still needs reading glasses, but at least she can drive at night now. Just had to do that in the dominant eye. So now we have a lens that does fulfill that promise in terms of an acceptable glare profile and an increased depth of focus. So this is the Vivity from Alcon, which we've been using for almost 18 months now. It uses wavefront shaping technology, and I find it easiest to understand when I look at physics and engineering explanations, not optics. So it's taking a laser wavefront and using shaping to change the profile. And on the lens optic, what this achieves is shifting and stretching of the wavefront such that there is an extended depth of focus in that eye after implantation. The light isn't split. You just, and under the microscope, you can see this element that's been placed onto the center of the optic, in contrast to the Symphony lens. This is helpful to show patients to illustrate how the lens provides distance and intermediate vision and how it starts to run out of juice when you get to the near vision. It's on a familiar hydrophobic platform and has a wide diopter range now, 10 to 30 diopters, and torics, 1 diopter up to 3 diopter. We've stuck with an A constant of 119.2, and with the dominant eye, aim for the first plus, and with the non-dominant eye, which we operate on second, we'll aim for some myopia and vary it according to the reading performance of the dominant eye. This is the first trial data that Alcon presented, so over 200 eyes in each arm, comparing the Vivity to the SN60, the Acrosoft IQ, showing that it had almost equivalent good unaided distance vision, slightly worse performance compared to the aspheric monofocal lens, but significantly increased unaided intermediate and near vision. Importantly, yes, this slide shows the improved performance at intermediate and near, but importantly, very good quality of vision when questioned on starbursts and halos and glare. Again, this is a questionnaire that's been developed by Alcon. So it isn't out there in the public domain as a validated tool for assessing quality of vision and quality of life. But it does appear to be giving us this side effect profile of a monofocal lens with increased spectacle independence, allowing us to use this blended vision type approach. So that after 100 bilateral implantations, I haven't had to discuss explantation with anybody. I don't have any patients who are having issues with inadequate night driving, but I have had 3 patients where I've had to laser them in order to improve performance. This case illustrates what I'm talking about. So we were 8 months post-op. He was euphoric at a week because the on-axis incisions that I placed temporally had resolved the small amount of against the rule corneal astigmatism that you see here on these pentacams. And then over the following months, that relaxed out. And this small amount of myopia and against the rule SIL was enough to cause this persistent ghosting on distance vision targets. And he was symptomatic. So great visual acuities for both unaided distance and near, but a complaint about visual quality. 2 months after LASIK to correct that, you see a slight reduction in the strength of the unaided near vision. So he's having to put reading specs on a little bit more, but he didn't mind because it had resolved the issue of the ghosting. This is an attempt, this paper hasn't been published yet, but it's been accepted by JCRS. And this is using yet another quality of vision assessment tool based on 25 questions. A low score is good, and you just see that there's a slight reduction in the satisfaction at the unaided near vision. The take-home message here, this is a really good paper that assessing the different tools, is that I think we really need one of the big societies to take the lead on giving us validated tools to help us assess these technologies and their impact on quality of vision, spectacle independence, and resultant quality of life improvement when we're using these multifocal and extended depth of focus lens technologies. We've got great technology now. We've really come a long way in the range of issues we can address for our patients in our quest to improve their quality of life. And I would love to just finish with this case of this 75-year-old lady recently treated at my clinic who illustrates what we can do and the limitations of what we can do, diagnosed with wet and dry AMD, 10 injections in the right eye, 6-month history of gradually increasing haziness of vision. Those are OCT scans, a good amount of nuclear sclerotic cataract in both eyes. And this was my mother. And my colleague, Jack Gormley, very kindly did beautiful cataract surgery on her with monofocal lenses and secured what we're after, which is that massive improvement in quality of life despite those macular changes. And yes, she can thread a needle, just needs glasses to do it. Thank you very much.
Thank you, James. That was really good. I mean, it encapsulates what all of this is about. And your recent experience, is this your favourite lens now, the Vivity?
Well, what we've moved to, and when I set the clinic up 5 years ago, we made a really big deal about the fact we weren't tied into any manufacturer, and we were absolutely customizing it based on everything we found with the patient, their lifestyle, their eye anatomy. And we were using lenses from at least 6 different manufacturers, measuring corneal spherical aberration, doing all these things. And now it's ended up pretty simple that we're using PanOptix Vivity and the SN60, SN6AT. And so we're using a lot of monofocal lenses, still using some PanOptix, and tailoring our lens selection so that it is still customized, but it's become simplified by the fact that we can get maximum spectacle independence with the PanOptix in people who don't drive much. We still have to look after quality of vision in people who have compromised maculars and optic nerve disease. And for patients who are very active and driving and playing a lot of golf and don't mind putting on readers for looking at very small print or dim light conditions, absolutely we can use the Vivity.
And that's obviously made your conversation preoperatively much simpler.
Yeah, absolutely it has. So it just gets down to the number of what's the main frustration the patient has, then looking at what they're bringing to the table, and then guiding them and saying, look, this is the technology for you, and these are the benefits, and these are the limitations.
James, thanks for that lovely talk. We chatted about this informally, but I just want you to share the experience with both the live and the virtual audience about refractive targeting for these patients. I've been using Vivity for the last, probably I've done about 50 or 60. It is not giving the same amount of unaided near vision as you would do with the traditional presbyopia correcting trifocal IOL. So we are going into this domain of doing the dominant eye for emetropia and doing this micromonovision with the non-dominant eye. How does it play now that we are becoming more and more comfortable doing ISBCS? Is that almost a contraindication for ISBCS, or how do you play this with ISBCS?
Yeah, so it's the main reason that I don't do ISBCS, is because I don't want to miss the window of opportunity to adjust the lens power calculation for the non-dominant eye. I think you could. I think you get great results, and most of the time you predict it really well. But I think it's just nice to have that opportunity. So what we've found is that our lens surgery patients have dovetailed into our laser eye surgery practice. So for all of our patients over 45, we undertake a refraction and then a loose lens tolerance test in order to assess their individual tolerance of anisometropia. And then for the patients who turn out to be more suitable for lens surgery because they've got some early cataract change or dry eye or contraindicated for LASIK, we've got a handle on whether they start to notice a difference at -0.5, -0.75, whether actually you can push them down to -1, -1.25. And then that emboldens you when you're planning for the Vivity. And then, as I said, with the dominant eye, we aim for the first plus, and then have a couple of lenses lined up for the non-dominant eye around that target that we've determined would be most suitable based on that loose lens tolerance.
Yeah, but just waiting for a week for the second eye, do you think that is enough time for kind of the ELP to settle down?
No, but it gives you a rough idea, and it helps you pick out the superstars. So you're absolutely right. You have to be prepared for the fact there'll be patients who are 6'5" and N8, N10. But you get some patients who are 6'5", N5, and I don't quite know how they're doing it. But you've got them, and you just go same again, and they'll love you. So it's probably more helpful there. And you're right. A week is not soon enough. You'll see the prescription alter, and it's 12 weeks when you get close to your final stable prescription, and they seem to drift forward a little bit. So they seem to go forward about -1/4, -1/2 over that 12-week period.
Got any audience questions here?
James, that was really interesting.
Hang on, just wait a moment. We need a mic.
Right, no worries. James, that was a great talk. Do you have any experience with unilateral vivities? Like if they had their first eye probably with the NHS, and now they want a bit more, or they had vivity for the first eye, and you thought for some reason that they might benefit from a monofocal in the other eye?
Yeah, we've got a small cohort of those patients, and they've mostly arrived by accident. Either exactly as you described, they had a monofocal lens already in the dominant eye previously, or they're really very relaxed about needing readers, and they're really clear about the fact that they want their distance vision to be amazing. I don't know, drive fast cars, or it's. So yes, we've just popped vivity in the non-dominant eye. Then we've had a couple of patients recently who've had, interestingly, their post-laser eye surgery, where they had monovision treatments for myopia, and the dominant eye is almost like a normal cornea. So, a really common question in these kind of forums is, what can you do if they've had previous LASIK? And I would say, well, it depends. It depends on the LASIK. So if they just had -2 treated with a modern profile, it's a normal cornea. If they had a fair chunk of laser on an older ablation profile, they've basically got like a lot of depth of focus on their cornea. So you can just use a neutral lens, and I have some depth of focus. And so we've had a couple of patients where the eye that had the bigger treatment, we've just put a monofocal lens, and the one that was hardly touched, we put a vivity in to get that increased depth, and we've restored a nice blended vision approach. So it is a really safe tool, I think, to add in, where as you clearly have done with a monofocal in the other eye.
I just find that the quality.
Just hang on a second. Mike, there we go.
Oh, hello. I just find that the quality of image in both eyes are very similar with the monofocal and vivity, and probably that's why patients are happier to kind of like accept unilateral vivity versus monofocal.
Anybody else got any questions? Yeah.
James, again, a great talk. Hi, James. I'm struggling with this idea that there are some patients who are very sensitive to astigmatism, but also we can accept a little bit of residual astigmatism. Do you have anything that helps you point out those patients who are going to get the ghosting, or who are really going to suffer if you leave them with half a diopter?
No, and I've thought about this a lot, because you hear these statements from manufacturers and also at meetings. So, everyone's fine if you can get it down to 0.75 diopters, and it's just not true. A lot of patients will be fine, but we know from Pablo Artel's work that half a diopter is the magic number. But and if you get it to half or less, the visual system will cope with it. And what I didn't show with that case is that when we refracted that guy the previous time, he had 0.75 diopter against the rule. So he was just tipping outside a half. And I think that's why he was symptomatic. And then I've never really understood it, but it just seems to be a bit more significant if it's against the rule than with the rule. I'm really aggressive about using the toric lenses. So we've constructed a financial model so that the only conversation with the patient about toric lenses is, I'm going to use a toric lens, and the only downside is I might have to rotate it for you. We don't get into cost or whether it's worth it, or that's my job, to just look after it. And it means, 45% of our patients are now having torics, and a lot of the 82s or the DFT 215s And it's when they've got that small amount of against the rule. So yeah, if they've got half against the rule, they're getting a 215 or an 82. With the rule, no, sure, I'll come from the top, and that'll flatten it off. So I think that's the story there, is that if you can get it to under half, you're golden. 0.75, some patients will let you off, but you'll start to have people complain, and you either say this is as good as it can be, or you keep working on them.
Can I ask one other question as a follow-up? Because you see some patients who have very low amounts of corneal astigmatism, but they have an abnormal spherical aberration, so their root mean squares over 0.5 microns. I typically shy away from putting a multifocal into those patients because they seem to get more glare and halos, whether that's just a couple of bad experiences. But do you think those patients are more appropriate for something like the Vivity, where the cornea is not 100% regular, but there's still no huge amounts of manifest astigmatism?
Yeah, so I think you're absolutely right to pick those patients out. I think the Vivity is a bit more forgiving. And then also, once you've got that much spherical aberration on the cornea, you can do quite a lot with monofocal lenses. They've got some depth of focus, natural depth of focus, and there really is an argument for just riding that wave and just, you've got, there's a few things you can do, but yeah, putting in an AT, an SA60 lens, for example. And they'll have quite a nice range of focus without having to go to any fancy technology on the optics. So I think the Vivity sits in between those two approaches.
James, we've got time for one question from the audience here.
So the dysphotopsias.
Should we better say what the question is?
I'm so sorry. Yeah.
The question is there a difference in the patient's reported outcomes with dysphotopsias between Vivity and other EDOFs or multifocal lenses?
Yes, this is from Phil Buckhurst, who's very knowledgeable and a friend. Hello, Phil. Thank you for that question. So the short answer is yes. What I really want to be able to do is for us to standardize these tools that we've been discussing to assess quality of vision more in a more standardized way across all the platforms. But absolutely, we're not having anyone so far saying to us they can't drive at night, or those kind of challenges that once you're 100 bilateral patients in, you will have that conversation with a Zeiss trifocal or a Panoptics.
I think the optics are completely different from multifocals, which is diffractive, compared to wavefront elongating technology with the Vivity. But thanks, James. That was a great talk. And in the interest of time, we'll move on. May I call upon Arthur Cummings? Arthur?
Hello, Sathish and Richard and James. Really enjoyed your talk. So we're going to be speaking about, Sanjay and I, about the Argos biometer. So Chris, fantastic. There we go. All right. So why did I acquire an Argos more than 4 years ago? I just want to give you a bit of the history. I'm going to speak mostly about Argos, while Sanjay is going to speak about Argos with image guidance. So I've always used two biometers in the practice. I've always just done that. And what I had before I got the Argos was an LS900, the Lenstar, and I just found it was performing better than the IL Master, and was thinking it's time to get a new biometer. I needed to replace the IL Master 500. And then Ted from Daybreak Medical came in one day and said, I've got this new device, the Argos, and he mentioned that it had segmental axial length measurement. And I'd been working on a project for a while called ClearSight, where we did exactly that. We did segmental measurements and then ray traced, and I knew it had value. So I liked the fact that it was swept source, OCT, and also liked the fact that it had these segmental axial length measurements. So I started in July of 2017 working with this device. And then in October of 18, a year later, basically, I was at a medical advisory board meeting in the States with Alcon. And at this advisory board meeting, they suggested they were wanting to get into the biometry space, and they were looking at a company called Movu Argos. Have you ever heard of it? And I said, well, I've actually used this device for the last year and had something like 300 cases measured on both devices, so I understood it to a certain extent. And they then asked, well, I said I'd be happy to give the results to them or the data to them. And they said, well, unfortunately, they can't do that. It's not the way things work anymore. And so I could report that we had very good results. We were happy with that. And then also, as far as all our devices go, it was the single device that detects like most to use. It was just very simple to use. And so the only way that I could provide the data to Alcon was through an IIT. So we wrote up an IIT, an investigator-initiated trial, published it about a year ago on the comparative analysis of swept source, OCT tomography, and partial coherence interferometry parameters in the prediction of cataract surgery refractive outcomes. So basically comparing the LS900 to the Argos, but then also in terms of keratometry, comparing those two devices also additionally to the Pentacam and a Placido disc device. And so I think all I wanted to show you, I know my point is not working, so it's in the middle of the slide. There was a strong correlation between the two devices in eyes with an axial length between 20 and 30 millimeters. The Argos displayed a tendency to measure long eyes a fraction shorter, while the short eyes measured a fraction longer than the LS900. And we sort of expected that because of the segmental axial length. And if you look at this bland Altman plot, you can see where, generally speaking, the axial length measurements were very, very similar. But there was the shortened long eyes and the lengthened short eyes with the Argos. But overall, the distribution of axial length was identical. And that's what you find with optical barometers. They're very, very accurate. But the point is, in all the optical barometers to date have basically changed the time of flight with light to an ultrasound equivalent to make the formulas work. The more modern formulas now are actually using the proper time of flight. So the median refractive index determines the degree of conversion, and a single refractive index is used by the PCI barometers across all media, while in contrast, the Argos swept source uses these individual refractive indices, something different for the cornea, for the aqueous and the vitreous, and for a cataract. And these axial length measurement differences are probably due to this difference in the application of the refractive indices. So overall, it's a device we've been very, very happy with. It's our go-to device now, and it has been for a long time. There's hardly a lens we can't measure. The measurements are very, very quick. Now, Sanjay has had the pleasure of using the advancement of what I've been using, where the alconization of the Argos device along with image guidance. I'm looking forward to your talk, Sanjay. Thanks very much for your attention.
Thanks, Arthur. Any questions from the audience?
Arthur, can I ask you, in relation to the segmentalism of the way that Argos works, what happens with the vitrectomized eye or an eye with silicon oil in the vitreous cavity?
So at the moment, nothing, Richard, but I would imagine that in time we'll be able to make that adjustment on those segments. But right now, it's not something we really see much. It might be that it's there already. It's just not something that we see much in our practice.
Mm-hmm. And which is your current formula of choice when you're using this device?
So we mostly use the Barrett, but we also use SRKT sometimes for long eyes and half a Q for short eyes. And most times we would look at least two formulas on both devices and get the best idea. And as you and I spoke earlier, more and more nowadays, we're also using this information and putting it onto the AI formulas, like alpha QST or DGS or LADAS, any one of those.
And do you find that that's making your extreme eyes more accurate?
Yeah, absolutely.
We've got any audience questions for Arthur?
Arthur, may I ask you, do you have any information on how this compares to IOL Master 700?
So I don't have personal information, but I do have from colleagues who are saying that in fact they're getting more eyes measured with the Argos than are with the IOL 700. And additionally, that they're also finding it easier and quicker. So I can't speak from personal experience, but perhaps Sanjay can. I'm not sure if Sanjay's looked at that.
Okay.
Yes, I think.
Sanjay, are you ready to give your presentation?
Mm-hmm. Thank you very much. It's great to follow after two great speakers here. So I had the opportunity to use just a month trial of Argos. And this was obviously very exciting for me at a time where, what we were hoping to access is with a biometer with image guidance. So I think rather than saying it, I thought I better dive into a scenario that most of us are facing at the moment with post-pandemic, where this is a very normal scenario, whether it's NHS or private practice. And this patient who came with 636 vision, dense cataract, dense posterior subcapsular lentil opacity, and 4 diopters of corneal astigmatism. Now, normally, I just thought it's best to show. I work at 2 practices, and I think this is how my current practice would be. So my current practice at the moment is this patient. The technician does the first measurement, and the first measurement is a lens mask, lens star, and basically the patient is asked to fixate on a light, and they're looking right in the center of the fixation on the red light, and they get a series of measurement, about 5 measurements for each eye. I think the most difference bit here is with every blink you have to there's about 5 or 6 flashes, which is sometimes a bit difficult for people with narrow palpebral aperture or who've got dry eyes, or older patients, particularly if the vision is poor and their fixation is very difficult because of a dense cataract. So you would do this, and typically this would take them about a minute or 2. Typically, then this patient who's got astigmatism will then go on to one of my practices that I work in, has got Verion, which is image guided, and effectively it identifies your limbal blood vessels, and it's a very accurate way to plan your toric lenses. And so they go on to have that. And again, effectively what you're looking at is all the 4 dots on the right has to be green. So it goes like an amber, yellow, green, and it needs to be all 4 green. So it does take a bit of time to acquire this. And then with some good luck, then once you get the green ring, then you actually get ask them to blink, and then you get the steep axis, and so that is the next part of the acquisition for this particular patient. And unfortunately, because one actual length couldn't be measured because of dense cataract, then obviously patient needs a scan. So there's additional time. There's subjective variation. In one place, I do it myself, and the other place, there's a technician who does it. But indentation effect, and we all know that optical biometry now is the gold standard. And whenever you do an A scan, you always say there's a risk of refractive surprise because it's measuring from an ILM, as though no foveal fixation, and there's risks associated with it. So hence this patient. Now, the advantage during this time, carrying on with the same patient, I would then, on the day of the surgery, do a reference axis, manual toric marker, as James Wall has correctly touched, that at one practice I work and I do, I've got a manual marking, and the other place where I work is connected to a Verion image-guided measurement. And I think whilst I would say higher astigmatism, I always do under Verion, but I think overall, most of them, as long as you've reduced their astigmatism to, it's actually pretty accurate, particularly with experience. So then you would go on to and do an online calculation, use Barrett formula, and then do a toric lens calculation. So this is my current practice in somebody who's got a dense cataract and a high astigmatism. Now, we had a short experience with Argos, and I think what I was quite looking forward to use during this time was because of the concept of sweat source OCT, as Arthur has touched on, and the segmental which is supposed to be more accurate. So I think that also gave me something, an exciting prospect to look forward to. The acquiring with Argos is fairly easy. It's a bit like when you do an oculizer or a pentacam, where you're matching almost the apex of the cornea and then matching in the center of the ring. And you get almost 6 measurements, and it analyzes 3 of them and gives you best axial length and keratometry reading. So it is pretty quick in that, and actually the technicians during this time, we kind of timed it, and we felt that certainly acquiring through the Argos during this period, we felt it was a lot shorter. Even if they were not used to it, they were more used to Lenstar actually at the time, because they've been using it for years. Like any other biometer, all the current biometers, obviously it gives you antechamber depth, corneal diameter, corneal thickness. For all the modern formulas, it gets into for all the. But what I surgically liked it is the planning, and I think that was quite a good thing for planning, for getting a printout, communication, reducing reducing a bottleneck in terms of the time that you spend. So effectively, it gives you the option of having a monofocal lens, but it also tells you at the bottom of the screen, there's astigmatism correction planner, i.e., if this doesn't need anything to be addressed, it'll say no arcs. If you then think there is an astigmatism, it'll do the astigmatic calculation with all the formulas like Barrett, Holliday 2, Haggis, NSRKT, and gives you a planning. So for example, in this one, it tells you that's 20.5 diopter, SN682, and the implantation axis. And then there is a little column at the end where if a surgical planner, it gives you a printout of the surgical plan, which is great in one go. And I thought that was very, very, it reduces the risk of transferring data from writing it, doing it manually, and I thought that was very, very useful. Also, if you were doing a standard monofocal lens, but it's still, if you had access to arcuate keratotomy, whether it's manual or through femto, it does give you idea that if it's less than 0.75, but it can give you idea about paired arcs or not, and gives you gives you where to do it. So I think overall, I felt the surgical planning was very, very intuitive, easy, and quite easy to adapt. So in that 1 month period, I felt overall that the bottleneck, particularly with these patients who got denser cataract, it definitely felt that there was a reduction. And I can identify almost in the period of 1 month, at least 18 patients, which we could not go through the normal pathway of acquiring it through Lenstar. We could actually get in that short time. And then looking at some evidence, it shows almost 83% reduction of time. And in terms of getting the acquisition, there is an enhanced retina visualization mode, which kind of you felt that the first time that they would do it through a dense cataract, let's say if the measurement was not that good, you could put that mode on, and it did work better. So the overall acquisition was higher, as you can see from this data here. So why does it do that? I had in a very short time, I'm not so sure. However, what's claimed is probably due to the longer wavelength of 1060, that it causes less diffraction and better penetration, is what the claim has to be. And again, the enhanced retinal visualization mode helps better through denser cataracts. So overall, in that short period, what I felt was the technicians found it quite useful in terms of a better acquisition, faster. They also felt that if the measurement were not good, deleting and capturing and deleting was very easy. And what I found good as a surgeon is the data transfer and reviewing your image capture and planning. And then the place where I have Verion, I could use a USB, and hopefully that could be connected to your microscope, and that would obviously help your planning a lot easier and less issues of transfer of data. A bit like what we do with Wavelight Suite. If you have Wavelight Suite, you transfer all the key readings and things through your oculizer and topolizer. So overall, I thought that did give the new Argos in terms of timing and efficiency. Then I started looking at evidence compared to the current biometers, and I think overall it compares with 700, 500, and Lenstar in terms of axial length. And as you would expect for all the modern biometers, it has a high correlation with the other in terms of keratometry. But there are some evidence out there that due to the segmental axial length, it may produce more accurate measurement for shorter and longer eyes. And actually, as surgeons, as we know, a normal axial length virgin eyes, i.e. not post LASIK, they're the easiest one, and your accuracy rate is always very good. It's mainly the 21 or near nanophthalmos or very, very high axial length are the ones which we're always worried about refractory surprise. So if anything could be done to be a bit more accurate, that would obviously be helpful for us. So there's some evidence of that. There is a paper in 2019 which compared the outcomes, and I think it was favorable for Argos in the long axial length group using Barrett 2 formula. And there is another study which shows to favor Argos in all axial length group, whether it's small, normal, and long axial length by Sharmas in 2020. So overall, I think this short experience I had over a month with Argos, with the image-guided one, I found that it was good for the technicians. It was reducing the bottleneck. It was efficient, and it obviously had more acquisition rate. And in time, if you could actually pair that up with your microscope and image guided, that could always be better. Thank you very much.
Very good. Thank you, Sanjay. That was really interesting, and obviously you have a positive experience here. Can I ask you a couple of questions? Normally in the past, when we're doing toric lenses, we would be taking measurements from more than one instrument. Do you feel that this instrument on its own is sufficient for you to get the measurements that you want for doing your toric lens implantation?
I think it's a bit like when we went to PanOptix and Vivity, because the platform was Acrosoft, that probably helped me. And I think it's a bit same here, because the principle is same as the Verion, and I've been using Verion to identify my toric lenses and measurements. Because of that, I've been using it for about 18 months. I felt quite comfortable using that, though for that trial period, I did use exactly what my current practice was, and I compared and did so that there was no, because I had to go back on a biometry, and that was only during demo period. But I think, in essence, to your question, I do think I would trust it because the principle is the same as the Verion, which I have been using it for a while.
And the second question relates to the OCT characteristics in terms of your ability to look at the posterior segment, which is one of the good features on the 700. And do you feel that you're comfortable with what you see in the posterior segment, or that you still have to continue to do a separate OCT on your patients having advanced lenses?
I think that's quite a good question. I do think if there was one patient in this which had asteroid hallosis, and I could see that, and that gave me a bit more confidence that if somebody had a dense cataract and if there was a vitreous hemorrhage or something else that you could see, but I obviously didn't have enough experience. At the moment, I still did an OCT all the time. However, and I don't think that will replace OCT, particularly for the posterior pole and macula, but I do think a vitreous space, maybe the more you acquire and more you have experience with it, that you might be a bit more comfortable. But at this point, I did find it was a bit more informative, a bit like, as you said, about 700, that you could see vitreous spaces, and if there was floaters or something which is not echogenic, but basically you could see a bit more compared to the others.
So one question from the audience: was the difference in the axial length of the long or short eye significant enough to indicate a different IOL power between the two devices?
Yes, the study that I quoted, they found the shorter eyes and the longer eyes. It was obviously the prediction of the IOL power was closer with Argos. Yes, it did lead to that.
But did that warrant a change in the selected IOL power?
Yes.
Okay. Thanks,
Sorry,
Sanjay. James?
I have a question for Arthur and Guy, actually, because I was interested that you used the SRKT, and Guy and Richard Sheard wrote that lovely paper about the mistake in the SRKT. So they came up with the T2 formula, and it's the eyes with the steep Ks, and you end up with these overpowered IOLs and a kind of myopic surprise. And so we use the spreadsheet. We put the numbers in, and that you kindly share on the on the website, because it can make a really significant difference.
Yeah.
I'm just interested you still have it as a.
But I mean, in relation to the SRKT and long eyes, you need to use the Wang-Koch adjustment, which actually overcomes that problem, so that you don't get the hyperopic.
I know that it's better to correct the mathematics of the formula, which is
I agree.
Which it did. And then also David Cook, who's an eye surgeon based in the US, has done a lot of comparisons of different formulae, and he has got access to, the mathematics from the authors of those formulas. So like Prof. Barrett's given him the maths, and Jack Holliday's given him the maths. And of the two variable formulae, the T2 really does remarkably well. And I think part of that is there's less errors to propagate through. And I do think that's a really underappreciated aspect of the whole biometry thing, because we've got these fantastic machines that really carry out very, very precise measurements, but they still have errors. And the Ks in particular are, on a lot of machines, a real lottery.
That is why I was suggesting, should you be using topography, tomography, and the biometry as well when you're looking at your Ks? And what do you think about that?
Well, unfortunately, I couldn't show it this evening, but I did shoot a video of how the topography changes throughout the blink. So it's really, really important to pick your moment. So for about the first 3 seconds of the blink, the tear film is all over the place. And if you use an automatic analyzer, it will come up with all sorts of ideas. And then from about 3.5 seconds to 7 seconds in a normal person, it's gives very good analysis. It's very stable. But then as the tear film begins to break up, it just completely loses the plot. So it goes, they've had hyperrefractive surgery. And then they go, no, they've got post-LASIK ectasia. And then, no, right, wait a minute, no, it's pellucid marginal degeneration. So the thing I really like about the lens star is the fact that you do have to laboriously get all those measurements, and you can pick your moment when you capture your Ks to make sure It's right in the center of the blink cycle. And if you look at the tear film when you're doing it, you can see when they blink, initially the tear film is all over the place, it settles down, you press the button, and then it falls apart. And what I always do is I keep on discarding the K outliers until I've got the standard deviation as small as I possibly can. And certainly for the SRKT, a 1 diopter error in the Ks gives a 1 diopter error in the post-refractive outcome. And Alice Erytropoulos' famous slide now does show that people with bad tear films get amazing refractive errors. I think her largest refractive error was 5.5 diopters. Can you just imagine explaining that away to a patient? It just would be no fun at all. I mean, it just, how would you? Now, I'm a terrific surgeon. Now, yes, I know you're 5.5 diopters out, and before you had a refractive error of -1.5, but it just would be horrible. Horrible.
Why do the machines have the T2 formulary?
I can't answer that question diplomatically.
Okay.
Okay,
but it is available on Richard's website, and it just give it a go. You can easily run it in parallel alongside what you do.
Guy, I mean, you said that the big error, and a big error is in the case, but the biggest problem we still have is predicting where the lens is actually going to end up. And that's where the variables really lie. I mean, we're getting pretty good now, but even, as you say, the machines are really good, but it's still that last hurdle which is the biggest problem for getting as many patients as possible into the ±1/2.
Absolutely. I think that, obviously is one of the holy grails of biometry, but another big problem is that when you're putting in a 24 diopter lens, you're not really putting in a 24 diopter lens. You're putting in a roughly 24 diopter lens.
Yeah.
When you get to the hyperopic patients and you're putting in a 36 diopter lens, you are maybe putting in a sort of a 35 or a 37, and it's much more critical for those short eyes. And then the other thing that I think is really underappreciated is, again, we've got all these amazing machines, okay, and the lens technologies are fantastic. And then everyone does. I was looking at the slide there when they were doing plus or minus quarter of a diopter. Everyone relies on the patient's refraction, which is if all 4 of us refracted the same patient, we'd all get something different. Or if I refracted a patient today and then did it tomorrow, it would be different. And it's also the chart distance is really important. You move the chart and you change the spherical equivalent. And when I was at Moorfields, they went around and measured all the charts in the hospital, and there wasn't a single chart in the hospital that was at 6 meters, not one. So you've got to, if you really are interested in your biometric outcomes, it does require a little bit of work, but if you do that work, you will get really nice results, and the most important thing of all, happy patients.
But you're right about the lens power, because none of the manufacturers put the real lens power on the box. And the actual tolerances that they're allowed to get away with are surprisingly large.
Well, the ISO tolerances
So it's quarter diopter.
Enormous.
Yeah.
So I think actually there might be a German company that as you'd expect, labels precisely. There is a West Indian company that gives the manufacturing tolerances. It states what their maximum tolerance is. But generally speaking, it's not that great. I think Alcon's is much better than the ISO standard. So.
Okay, any questions from the audience? If not, Guy,
Okay.
we'll let you wrap
I
this
know,
up.
I've got one over here.
Oh, there is one. Beg your pardon.
In terms of the Argos, does it just take the case from a placido-based keratometry? Because you'd think a lot of these tear film problems would go away if you took them from the OCT. And does it do a posterior corneal measurement from the OCT? Just for maybe Arthur and Sanjay. I don't really know much about the technology.
So as far as I know, it doesn't take a posterior measurement. It takes a corneal thickness, but it doesn't have enough data on the posterior cornea to give you a precise measurement. And most of the devices today don't. So Barrett and some of the online formulas take into account the expected posterior corneal astigmatism. And that's turned out to be more accurate than actually measuring it yourself. And sorry, what was the other question?
Are the Ks based just from the placido keratometry, or does the OCT feed into that data to look at actual curvature on OCT?
I don't think OCT is part of that, but I'm speaking under correction. I think it's just the placido.
Yep, I think so as well.
On Richard's question, Richard, I might just add something is, we use 4 devices for every case we do, every cataract we do. And traditionally, the 2 that are most accurate will be the biometers, and they're measuring at the right optical zone too. So the lens stars are really good at keratometry, and so is the Argos. Every now and then, if the tear film is really good, as Guy alluded to, you'd find that placido disc and shine fluid, which is agnostic to the tear film, they would often match. But on many eyes, you'd find that the placido disc and the shine fluid have a similar measurement, and they can be quite different, at least by up to even 1.5 from the biometers. And then it's better to go with what the biometer is measuring. They tend to be more accurate for predicting a lens power than topography or tomography.
Yeah, I mean, it's great when your devices all line up. That's fantastic. But when they don't line up, you've got to do something. And so your point, if you average them out, your shine fluid might skew things off. It's like the post-refractive surgery thing on the ASCRS website. It gives you all these different options, and I always do Barrett True K, and it's really good. I find it really good. Good to go. Yeah, I find the lens star good. I have an OPD3, which I find very nice. Yeah.
Okay, I think if there are no more questions, we'll move on to the last talk. Guy?
Okay, so I'm not going to try and do dry eye in 5 minutes. What I want to try and do is just show you really, because it's quite late now, very, very few slides that have really changed the way I think about dry eye. So, as always, we'll just start with a definition. So dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. And the reason why I like the definition, even if I don't like the term dry eye, is because it tells you in a really simple way how to approach the treatment. Something I don't like so much is this was the old Dew's classification of dry eye. And it makes it look like these are sort of isolated causes that you can just take out of the box, treat, and it'll all get better. But in reality, all these things are linked. So what I've done is I've taken all those factors from the previous slide and sort of tried to put them together in a way that shows you how they all can interact with each other. And the key here is that you can have a tear film instability problem that then starts causing a hyperosmolarity problem, and you can get into this vicious cycle that just amplifies everything. And you can also see that some things can just drive the process all by themselves. So preservatives down there in the bottom left. And this, I think, is one of the reasons that the various dry eye tests can give different suggestions and why treatment might not initially be very successful. So we're going to gloss over this, but the key here is the external milieu, the environmental factors that the patients subject to are really, really important, and you really need to get that across to patients. And it's not at all uncommon for me to hear patients say, well, they're referred with blurred vision, and then when the history is sort of taken, they say, well, their blurred vision comes on when they've been reading for a while. So it's not blurred vision caused by cataract, it's blurred vision caused by an unstable tear film. And if you just jump in and do the cataract, they'll come back and they'll say, yeah, well, that's fantastic, but I still get my blurred vision when I've been reading for a while. So better to address the dry eye before the surgery, because as surgeons, we're perceived to be much more convincing if we sort of tell patients things before they happen rather than afterwards and say, oh yeah, you've got dry eye. So, oh dear, something terrible has happened to the formatting of my slides. Never mind. So utility assessment is, I think, a very interesting idea. So basically, it's a way of comparing different conditions by asking a patient how many years of their life would they be prepared to give up to be completely rid of their disease, right? So this really surprised me. So admittedly, for severe dry eye, that's got a score of 0.56, and that's the same as renal dialysis. So as a junior doctor, I worked in the renal dialysis unit, and those patients were really, they were not healthy patients. And for them to be prepared to give up the same amount of years of life is quite surprising. And also with severe angina, you know, we've all heard that described as an elephant jumping on the chest, you know, that's got to be bad. Anxiety and depression are also much more common, which makes dealing with these patients a bit tricky. We know it's very common. So this, I think, is another very important slide. And what this slide tells you is about the sensitivity and the specificity of the various tests with particular cutoffs. And the cutoffs determine the sensitivity and specificity. But you can see that these tests, in the grand scheme of things, aren't very good, right? Which makes testing dry eye quite tricky. And remember, this is supposed to provoke conversation, so don't be offended. And this is why I think a lot of doctors are not nearly as good at diagnosing dry eye as they think they are. So if we just take the Sherman Test, right, which is very useful for diagnosing dry eye. So what I've plotted here, using the same metrics, is severe dry eye in pale blue, with a mean of about 9 and an upper 95 confidence interval of 24. And then we've got the mild and moderate dry eyes with a mean of 24 and a lower confidence interval of 9. And we can see that there's this large area of overlap where the test tells us nothing about the severity of that dry eye. So the only real use for the Sherman Test is if it's less than 8, they've got some sort of dry eye. Another way of looking at this is the ROC curve. So the area under the curve we want to be as large as possible. So if we look at our Sherman test, again, it's got the lowest area under the curve. It's really not a good test. And I can honestly tell you, I haven't asked for a Sherman test to be done in the last 10 years. So we need a good test. So osmolarity has been shown to have the largest area under the curve, and it can be divided up into normal, mild, moderate, and severe. And generally speaking, greater than 308 is considered to be abnormal. And it is important to do both eyes, because the difference between the eyes can be very informative, because the osmolarity of the tears should sort of mimic that of the blood. So if we get a big difference between the eyes, we know that the homeostasis of the tear film osmolarity has broken down. And I think this, oh dear, well, the main part of the slide has survived. I think this is probably the most influential slide for me. It completely changed the way I explain dry eye to patients. So what I tell them now is that your tears are evaporating all the time. When they evaporate, the tears that are left behind become more concentrated. That irritates your eye, and you produce more tears. And that brings the osmolarity back to normal. And in normal patients, that happens instantaneously and subconsciously. And I then tell them, if for whatever reason you can't produce enough tears to get your osmolarity back to normal, your tears become concentrated, and then you get inflammation. And inflammation causes the redness, the pain that patients with dry eye get, right? If you tell a patient who comes in and says, oh, I've got these painful watery eyes, and you say, yeah, they're dry, they don't get that. They just can't understand that they've got dry eyes and yet their eyes water. So, I really don't do that. So this also then tells you pretty much where you've got to begin. You've got to make the tears dilute. And this shows at baseline, we've got quite high osmolarity, and then we put a drop in, and the osmolarity begins to come down, but it doesn't really get down to that normal 308 for about, well, it's 60 minutes, about an hour. And then it stays below 308 for another hour, and then starts to go up again. Depends a little bit on what the drop is. So for patients who have got significant dry eye, if they're putting their drops in 3 times a day, they're treating themselves for 3 hours of the day. And if you think about a patient with hypertension, you really wouldn't want to be just controlling their hypertension for 3 hours of the day. So they need to use their drops more. And then this shows that after a week of treatment, the osmolarity comes down and pretty much stays down. And this shows the Sherman Test. The Sherman Test doesn't change. And really, why should it? Drops don't change the ability of the eye to secrete tears. So really, the Sherman Test is not useful. I really don't know why the big pharmaceutical companies still have it in lots of their trials. And I think maybe some of the disappointments they've had with some of their very expensive molecules may be due to this. We're going to skip over that, and we're going to skip over that. The next most significant slide for me is this one. So this was looking at 124 patients in a glaucoma clinic and doing their OSDI, their ocular surface disease index, and then they calculated the odds ratio, which is on the y-axis, based on the number of drops that they were receiving. And you can see that it sort of goes up. So more than 2 drops, 1.5 times the risk of ocular surface disease, more than 3, 2.5, and then more than 4 goes up to about 5. But you can see that the confidence interval, 16 times. So there'll be some patients who are very susceptible to benzalkonium. And even after multivariate analysis, the number of preserved drops is an independent risk factor of OSDI. So you can imagine that, say, a patient gets put on bimatoprost, and they get a bit of red eye, and then they go off to their GP, who very helpfully gives them some preserved hypramellos to use 4 times a day. So they're now on 5 preserved drops a day, and they didn't have an ocular surface disease problem before, but they might well now. and we've just created a problem, which is obviously not what we want to do. If we just go back to this slide, which again is a bit sort of basic sciencey for this time of the evening, but the take-home message from this slide is that a linear increase in the amount of benzalkonium in a drop produces an exponential effect on the corneal epithelium. Okay, and that 0.01%, that is a concentration that is used in many over-the-counter drops. So I think that is it, yeah. So I hope that will stimulate some conversation.
Guy, thank you. In relation to cataract and lens surgery, what is your view in terms of preoperative assessment we should be doing?
Well, I do think it changes a little bit depending upon whether we're putting in a monofocal lens or a multifocal lens. So I certainly think that they should have their epithelium checked for superficial punctate keratopathy. I think they should have their non-invasive tear breakup time checked as well to have a look at that, simply because when the tear film is unstable, you're not going to get accurate biometry, and the chances of a refractive surprise are much more. And for multifocals, I think it's absolutely essential that they really do have quite an involved pre-op workup, and I would do osmolarity as routine as part of that. And then just as I was coming in, I heard James saying about how the refraction doesn't stabilize for a while. So if you think post-op, potentially they could be having 12 preserved drops a day, so 4 chloramphenicol, 4 Maxidex, and 4 Acular. That is going to absolutely hammer their epithelium, which is good because, the critical thing post-op is we don't want them getting endophthalmitis. There's no point in getting someone within a quarter of a diopter of target if they get endophthalmitis, and we don't want them getting cystoid. But if you do their refraction during that time, you are not going to get an accurate measurement. And I totally agree with James's comment about, I think 12 weeks is about right. You can't realistically do that, I think, especially with a multifocal. You can't keep them waiting for their second eye for 12 weeks. But I think you have to be aware of that. But you can also reassure them if they are getting a little bit in the way of, post-op symptoms. A lot of that's their tear film. And when you clear their tear film up, they all of a sudden become a lot happier with their multifocal.
Do you think there's an argument for, in this situation where you've got all these other drops, using a preservative-free lubricant routinely with multifocal patients in the first few weeks after surgery?
No, I don't. I mean, they're putting in 12. I think it'd be more useful to use a preservative-free drop post-operatively. But as I said, there are advantages to preservatives. I mean, so if you give someone unpreserved acyclovir, it doesn't get past the epithelium. If you put a little bit of benzalkonium in that acyclovir, it gets into the stroma all the way through. You can treat hepatic eye disease like that. So, I think the most important thing is to understand, what the preservatives are doing for you and what they're doing against you. But I really wouldn't give post-op lubricants.
I thought along the same lines, and so what and came up with just something to try. So we can present it as an audit because we started doing it in a systematic way in September when we started our own lens theatre, which is we looked at Charles McGee's work on penetration of steroids, and you can't compete with a subconjunctival steroid at the end of the case. That gets a huge aqueous level. And then But we all stopped doing it because we did topical eye drops and it stung. And then, but if you do it, it allows you to use far fewer drops afterwards because you've put in your cefuroxime, so endophthalmitis tick. You've loaded up a load of anti-inflammatory, and then the steroid with the lowest concentration of benzalkonium is Predforte. That's really low. So we just do that BD for a few weeks, and then we use Bromphanac BD for 2 weeks, and then we give more high-low fort. And so my logic is, it all has to happen at the time of surgery, and afterwards, I want a bit of steroid and a bit of non-steroidal. But the service seems to get damaged enough by the bit of benzalkonium they're getting and me having stuck a knife in. And we've been studying CMO in a systematic way, and we've definitely reduced it. So we're at 800 eyes. We've only had one rebound uveitis, and our CMO rate is now down to 1 in 200 in the patients with they've got diabetes or hypertension. And whereas I was at 2% and it was usually after a rebound uveitis. And we've got it acceptable by using Midrain and then using it in the licensed way, which is a bit of intracameral, and then off-label I give a subconj, and I just stick the dexamethasone in that bleb of conjunctiva, and occasionally it stings, but very, very rare. Most people don't feel it. So it was thinking along the same lines, actually, going back to the pharmacology papers and saying, okay, well, we want to switch off the inflammation as quickly as possible. We want the antibiotics on board at the time of surgery. We know that's beneficial. And then I want as little of that poison going in afterwards.
I mean, the reason I was smiling is because I do still give a subconj, and even for topicals, and I get criticised by all my colleagues and all that sort of stuff. So it's really nice to hear you say that. And so I think I do think it's a really good idea. So I think one of the things, it's like injecting 5-FU into a bleb. If you just inject and then pull out, then you've got this high pressure under the conj, and it just all squirts out through your hole, so you don't get anything. So what you've got to do is you've got to stick the needle in there, inject your subconj of whatever, and then wait, which you need to wait about 30 seconds. What happens is the pressure normalizes, and then you take the needle out, and it's essentially self-sealing, and nothing comes out. And you can prove this with 5-FU, because with 5-FU, you put a little bit of a methocaine on there, and it all precipitates. So you can see it, that it works. Obviously, you can't visualize that with the subconj. And then, I also have a very, very low cystoid rate. I think partly because of that. And also, I've got a very low threshold for giving people pre-op Acular. And I use it 4 times a day for a week, which I heard Eric Donenfeld say that at some meeting, and I sort of started doing it, and it really made a huge, huge difference. And we were talking about investigations earlier on about OCT, so those diabetics, epiretinal membranes, all those people, they have much greater risk of getting post-op cystoid, and it is really disappointing, isn't it? When they've done so well and then drift back.
I'm with James, though. I think you should use something like Bromphanac because it doesn't sting. 4 times a day stinging does not make patients very compliant with Acular.
No.
Just on that point of the pre-op non-steroidals, when Bromphanac came in, I heard Donenfeld talk about using it pre-surgery. Mm-hmm. I thought this was a great idea. And we started trying to use it 3 days pre-op, which is what they said was the optimum. So Bromphanac BD for 3 days. And the patients kept forgetting. So then we said, okay, the week before. And that gave us much greater compliance. And then I couldn't prove it, but I think I had 3 cases of light toxicity in patients who were basically kind of clear lens exchange, minimal refractive error. The video showed there was just nothing out of the ordinary about the surgery, sort of 7 minutes long. And it turns out if you were going to design a molecule to potentiate light toxicity, it would look a lot like Bromphanac. So cyclic groups stick on a halide, and you get really good intraocular penetration right to the retina, which is why it's so great at treating macular edema. But there's work showing that kind of molecule can potentiate the excitotoxicity that no offense, but your generation really knew about this. No, you did. You used to worry about light toxicity, and you switched the light off and used the shields, and rightly, because light toxicity was a real thing, and you saw it. You'll have seen cases of it. Yeah. And then the microscopes got better, and the surgery got quicker, and my generation came in and went, it's fine. And then you saw people coming after your nice surgery going, I can't see anything in the middle there. And there was this whitening of the fovea, and thank God it eventually recovered. And again, looking at some basic science, thought, hang on, there might be an issue here. And I yellow carded it, and I let Bausch and Lomb know. But I never saw anything else come out about it. I just talk about it whenever it comes up in these discussions, just because
it's really interesting.
Rightly people go, I use Acular, and Acular is much safer if you look at the molecule design for that. But logically, people go, Bronfenac's probably better because it doesn't sting. And I just did this little experiment out of the best intention, which is to use it a week before, which no one has suggested. And I think I created a problem for 3 of my patients.
I think also those non-steroidals, they do all act slightly differently in how far down they will take the inflammation, whether they'll take it just down to baseline or whether they'll take it beyond that. So I think it does have to be sort of quite a personal choice, doesn't it?
But I don't think we need to feel bad about giving subconj. I think the pre-med study has very clearly showed that patients with diabetics, giving a subconj steroid at the end has the most effect in reducing the amount of CMO postoperatively. So I think the trend is becoming, we are all trying to go drop less. I think I've stopped using pre-op or post-op antibiotics since Peter Barry's study came out, and we started all using intracameral cefuroxime. So I think the trend is going towards using subconj steroids, intracameral kef, and nothing post-op.
My view is if I'm giving a subconj, I might as well put the antibiotic in there at the same time. But I am a disciple of Chris Lewes, who, he hates putting anything in the eye that he doesn't have to because of.
I think evidence is unequivocal now. Putting intracameral cefuroxime is the best place to have the antibiotic inside the eye, not subconj, not topical.
Well, I think there were some questions raised about the quality of that. It was an ESCRS study, wasn't it?
Correct,
and some of the groups that were being compared weren't like for like.
If you look at the study that was done in the States, the Kaiser Permanente study, that showed very clearly that when they introduced intracameral antibiotics, that their rates in a very large number of endophthalmitis went down.
Same. The 2 big study, one from Kaiser Permanente, about 40,000 eyes, other one from Aravind in India, looking at almost 100,000 eyes. Yeah. That's not even cefuroxime, that's intracameral moxie. So I think the evidence is pretty strong. Best place for antibiotics is in the anterior chamber at the end.
In terms of dropless, there's a new possibility, and we had a video in the video competition about this, the ESCRS, which Bobby Osher put in, and that's putting a little bleb of stuff just at the edge of the lens capsule, next to the edge of the lens. And he's done this now in several hundred patients with no ill effects, and has basically removed the need for postoperative drops.
Didn't Prof. Apple do that sort of years ago with drug-soaked lenses that eluted their antibiotic with time? That's right. There's actually a couple of startups looking at this at the moment, again.
I think the direction of travel with the pharma industry is to go intracameral, both with non-steroidal, steroidal, and antibiotics. So eventually we'll come to a stage, maybe in 5-7 years, I think we are looking at totally dropless cataract surgery in the postoperative period.
Well, Jim Gills did this about 20 years ago.
Exactly.
Where he was just putting stuff in at the end of the surgery and didn't use drops at all. Right. Okay. We're off.
We need to wrap up.
Okay, we're going to wrap up now. I think we've had a fantastic session. I hope you've enjoyed it, both those in the room and those down the wires. I'd like to thank all of the speakers for giving us this good evening entertainment, and I thank you all for attending.
Thank you.